All right, for those of you that are new or haven't talked to me yet, my name is Emma. I'm a fourth-year medical student currently applying for residency. I will be going through your virtual rounds today. Today we're talking about the cranial nerves and pathology associated with it. Clogged arteries, yes, that's right, Sammy, correct. I think we already talked about the aorta, but it goes right in line with everybody's side dishes that they chose. Everybody's choosing mac and cheese. I should have made it into a poll, which your guys' favorite Thanksgiving side dishes are. We had like one other thing, but mostly mac and cheese, it sounds like is the consensus. But speaking of Thanksgiving, a quick question for you all that are tuned in today. Do you guys want to do virtual rounds next Wednesday? We realize that it's the day before Thanksgiving. Let us know. Just put a quick yes or no into the chat and we'll kind of go with the consensus. Wow, everybody's dedicated. That's quick. Cool. Well, I'm teaching next week. We'll be talking about joint pain. I just looked it up before. So cool. We'll do it. I don't want to go out of town to see family yet. Yeah, that's the thing about the holidays, isn't it? All right, so we will do virtual rounds, same time, same place on Wednesday night next week. All right, so today, again, we're talking about the cranial nerves and the pathology. Here's a link that has all the resources that you'll need. And I had to add this in. I saw this meme and I had to add the video. And I hope you guys actually know, like, have watched Oprah. I really realize you guys are pretty young. So I added the video clip in, and then the meme on the right will make more sense. So here it is for you. So that's exactly what the meme on the right means. You get a neuro consult, you get a neuro consult. That was like the time Oprah gave away 1,000 cars on her show. So all right, so let me start the poll for you guys. Let me launch it here. So same question as always. How much do you know about the cranial nerves and or neurology? All right, most of you guys are in there. Let's stop it and share it. So kind of scattered all over the place. Some people know a little bit, some people know some, almost split right down the middle for every single one almost. And then some of you don't know a lot at all, which is fine wherever you're at. Let's see if we can change that and kind of shift you down a little bit more. All right, so I don't want to play the video again. It keeps making me want to play it. All right, so today we're back to kind of our, regular old one case, not the mini cases, though I'm thinking for joint pain next week, we will also do multiple mini cases just because it's easier and there's so many things. For this one, I wanted to focus on one specific case, and it's evidently more common than I thought, and you'll see what it is. Is our doctor the doctor? Yes, exactly. That's the doctor over there. His name's Bruno. But we will kind of go through one complete case. We'll talk about the history. We'll talk about the physical exam. We'll talk about different case details. Then we'll kind of make a differential diagnosis and an assessment and plan. Then we'll kind of go into the pathology behind the disease. And neurology is hard. We're really just skimming the surface here with neurology, but I hope to teach you guys a little bit and keep it simple and try to have some fun with this case. So what's your guys' role? Participate, tell me good jokes, ask questions if you have them. I love to answer questions. And then fill out that SOAP note form so that you can get, credit for the session. There will be the quiz at the end of it. I made the quiz, and I think it's fairly easy. And if you guys ever have any problems with it, or a question's hard, or something's wrong, let me know the next time you see me. You can yell at me the next week if there's something wrong with the quiz, or if the questions are too hard, just let me know. And then the quiz will be due the Tuesday, so right before the next session, your quiz will be due, and then you'll get that certificate for completion, and then you can put it in your application later on. Okay. So here's the SOAP note form, and it's fairly simple, and I'm not looking for a whole dissertation here. If you guys get the main points, that's excellent. This is a lot mainly for your practice, so that you have some exposure to this before you get into medical school. So the S is for subjective. So this is like the HPI and the ROS. So HPI means history of present illness. ROS means review of systems. So the history of present illness is, what the patient's telling us about what's going on, okay? And then the ROS is pertinent positives or negatives that have to do with the chief complaint, okay? So if somebody comes in with a headache, we might want to ask, are they having visual changes, or nausea and vomiting, things that are pertinent to what's going on, okay? Then objective is the vital signs, and then physical exam, so things that we are finding, all right? And then the assessment is essentially our differential diagnosis, and then the plan is basically what we're going to do based on the differential, okay? So fairly simple. If you guys have questions about that, just let me know. All right, so mark where you are in the world. We'll see if we have a good spread this time. There's been lots of people from the East Coast. So we have Tennessee, we have some Michigan. All right, lots of East Coasters as always. We have an Illinois, Texas. No one's ever in Florida or New Mexico. We have a Utah, excellent. 2 Californias. All right, well, wherever you guys are, welcome. Thanks for coming. I appreciate your guys' time. This is always certainly a highlight of my week. Oh, originally from Florida. Where are you from, Rachel? Jupiter, Florida. I'm like vaguely familiar with it. I live in Pensacola, so I don't know. I don't think it's that close, but all right, let's keep going here. All right, so first we're going to talk about the cranial nerves. So don't go cross-eyed just yet. We're going to walk through these and kind of keep it simple, all right? So when we talk about the cranial nerves, there's 12 sets of cranial nerves, okay? And they're paired. So the first one, and usually we put these as Roman numerals, all right? So first is the olfactory nerve. That's cranial nerve 1. That's this one up here, and it kind of comes out as a bulb. The cranial nerve 1 is primarily for your sense of smell, okay? And then we have cranial nerve 2, 3, and 4. The cranial nerve 2 is the optic nerve. Cranial nerve 3, 4, and 6 are cranial nerves of which control eye movement. Okay, so the optic nerve, exactly like you would think, is for eyesight, and then 3, 4, and 6 are for movements of the eye. So we have a plethora of muscles of which attach to the eye and allow us to move one direction or the other, or up and down, and turn the actual eye. So the way that we remember it is 3, 4, 6 make the eyes do tricks. Okay, so so far it's simple, but it gets a little more complicated. So then we have cranial nerve 5, which is the trigeminal nerve. That has a motor component, yes, but it also has a sensory component to the face. So there's branches of the trigeminal nerve. We have branches that come out on the upper part of the face and then the lower part of the face. And then if we keep going on here, we have the facial nerve, which goes to the face, controls some muscle, some movements of the facial muscles. Then we have the vestibulocochlear nerve, which is for hearing, inner ear, and balance. Then we go to cranial nerve 9, the glossopharyngeal nerve, controls movements of the tongue and some parts of sensation of the tongue. We have hypoglossal also for the tongue. And then the vagus nerve, that's a big nerve, it has a ton of functions throughout the body. It controls a lot of sympathetic nervous system to a lot of the thorax and a lot of the abdomen. All right. And the accessory nerve that controls a lot of movements of the trap. So and then the sternocleidomastoid. All right, so that's a brief introduction, and we're going to talk a little bit here about where they kind of come from based on their location. So that's how we can pinpoint whether something's going wrong, where we can localize the lesion. So, you know, for instance, if we say, you know, there's a problem with cranial nerve 5, the trigeminal nerve, we might locate the lesion to the pons. Okay, so the things that we look at here is the parts of the brainstem, the midbrain, pons, and the medulla. All right, so this is closer up towards the actual brain, and then this is closer to the feet. Okay, so then, you know, we kind of, there's a rule of certain ones in pairs that are in certain areas of the brainstem, but we'll kind of keep it simple here because we know that cranial nerve 2 is part of it comes off of the midbrain. Then we have cranial nerve 3 here, just in between the midbrain and the pons. Then we have cranial nerves 4, 5, 6, and then part of 7 here as well. And then cranial nerve 7 and 8 kind of travel together here. That's why they often get, when you have a lesion of one, you sometimes have a lesion of the other, depending on where you're at in the brainstem. And then we see 9, 10, 11, and 12 all come off here at the medulla, okay? So I don't expect you guys to remember that, you know, based off of tonight. And trust me, there's no questions that are this extensive about this specifically. The questions that I asked you on the quiz are fairly simple. All right. And then here's a huge chart. I do want to focus on a few of the cranial nerves. So if we look at, you know, for instance, we'll start at the top. Cranial nerve 1, the olfactory nerve, as we kind of talked about for your sense of smell. It kind of permeates the cribriform plate and then is associated with your sense of smell. Then we have the optic nerve, also a sensory nerve, and is for your vision. We'll see the importance of that here in this lesson today. Then we have 3, 4, and then 6. We know that these are for eye movements. We're not going to focus on the you know, specific eye movements that they do today, but know that they are involved in eye movements. Okay. Then we have trigeminal nerve. We get sensation of the face here, and then it also controls the muscles of mastication for chewing. Okay, so that's what I was talking about, some of the muscles on the face, it's for chewing. All right, then we go to the facial nerve, and this is primarily for muscles of facial expression. So when you see physicians say, all right, close your eyes real tight, we're testing the facial nerve there. Or if we're saying puff out your cheeks, that's also the facial nerve. All right. And then the vestibular cochlear nerve, that's for hearing and balance, as I kind of said before. Technically, it's 2 different nerves, but they're kind of combined in one, truly. Glossopharyngeal nerve, that is we have a sensory component and a motor component. So the sensory component is for the posterior part of the tongue, and then it also controls a little bit of taste. And then it also has, you know, different chemoreceptors, baroreceptors, but we're not going to get into that kind of depth today. Other than that, here's our friend, the vagus nerve. A lot of autonomic functions, as we kind of talked about, also controls the heart. So when we talk about the thorax and the abdomen, that's what it's for. And then the vagus nerve also has motor component for swallowing as well. All right, then here's our friend, the spinal accessory nerve. This is for, neck muscles, and then hypoglossal nerve. That's hypoglossal nerve is for movements of the tongue. Okay, so there's a quick kind of overview of that. We see, the location of here and how it relates to, different reflexes. We're not going to go in that kind of depth today, but this is just a quick introduction to the cranial nerves, the nerves that kind of are located within the brainstem and control, different sensory and motor functions. So the things that I want you to take away from this is that, 1, there's 12 sets of cranial nerves. 2, they're located on the brainstem. And 3, based on what is going wrong with the patient, based on their symptoms, we can locate where the lesion is. So if somebody has a stroke, we can locate where the lesion is based on what is going wrong with these cranial nerves, based on their sensory and motor function. Okay, so that's primarily what I want you to get of this. We're going to talk about a specific case here as well, and go into a little more depth. But if you guys have any questions, just let me know. All right, here's the first case, which is the only case. So I don't know why I titled it case 1. All right, so a 33-year-old female presents with a 6-month history of headaches. She describes generalized headaches that are diffuse. They do not radiate and are not associated with a specific trigger, including menstrual cycles. The patient's spouse is present for the interview and indicates that the patient has had multiple car accidents over the last 6 months and appears to not see objects in the periphery. She notes some fatigue, but denies nausea, vomiting, and diarrhea, dizziness, lightheadedness, or syncope. The patient describes that she has been well otherwise, but has noticed she has not had a period for the last 4 months and describes occasional nipple discharge. So I want you guys to now get your annotate button out and pull out your pen, whatever color that you want. And I want you to underline symptoms or details that are important in this vignette. Usually I bold this for you, but I want you guys to start to think and pinpoint details that are important. So go ahead whenever you're ready. Good. We have not having a period for the last 4 months. We call that amenorrhea. Good. Nipple discharge, certainly. Not seeing objects in her periphery. Sure. Multiple car accidents. Yep. It does not radiate. Good. Somebody underline that. Not associated with a specific trigger. 6 months. Good. I was waiting for someone to just underline the whole vignette, but you guys didn't do that, luckily. One thing that I'm going to add that you guys skipped is including menstrual cycles. Why would somebody include that in their vignette, that it's not associated with menstrual cycles? Yeah, so endocrine things could be happening. You're right, Stephanie. And sometimes with different hormonal fluctuations, some women get migraines around their period. So there's the link, Jerome. You can access the slides and the soap note from there. And right, I think Megan said it, because hormonal fluctuations can cause headaches. Absolutely. So what tests do you guys want to order? What else or what questions do you want to know at this point? Any additional questions that you want to ask this patient? Rachel wants a CT. Okay. All right, so I cleared that. Ask if they're taking birth control. Certainly, yeah, sure. Why do you want to know that? Good. Curious if she felt anything caused the car accidents. So you're trying to like pinpoint if she's actually just a bad driver or whether this is a medical cause. Yeah, trying to get pregnant, certainly. Anything else you want to ask her? Yeah, phonophobic, photophobic, good. So for those of you that don't know what that is if noise kind of makes the headache worse or light makes the headache worse. Good. Pre-existing risk for glaucoma? Sure, yeah, we can ask if, the patient has diabetes, anything like that. Any weakness or tingling? Good. Extent of the car accident, history of head trauma? Good. You guys are asking good questions. Any visual disturbances? Certainly. What about her past medical history? What do you want to ask? Or just her history in general? Have we gotten a complete history for this patient, of whom is 33 years old? We don't know a lot about her just yet. What else do we want to ask? Yeah, she has a past medical history of migraines, certainly. Anything else? Yeah, her history with her blood pressure. She could have high blood pressure. It's not uncommon. Anything else? Recent pregnancy, sure. That's a good question to ask, Harley, especially because having nipple discharge when you're not actually lactating is abnormal, so good. Anybody else? Any other questions? Any family history, medication, drug use? Good. Way to get to the bottom of the history. That's important. There's one thing that I want to know, and it's associated with the timing of the headaches. Why would I want to know when the headache is worse? Does anybody know? Could correlate with the car accidents, light-induced headaches. Yeah, so it's a little bit of photophobia. What else with the timing? If she says that, the headaches are worse when I'm laying down and they're worse in the morning, she could have a food intolerance. Positional, yes. Okay, so here's a little bit more of her history. And if you guys have any additional questions that you want to ask her, go ahead and throw them in the chat as we're kind of going along. Okay. So her past medical history, she has none, so it's pretty non-contributory there. Past surgical history, nothing. She had her wisdom teeth out, not a lot. She doesn't drink. She doesn't smoke. Her mom has high blood pressure. Her dad had prostate cancer. She doesn't take any medications. That's important to always ask. A lot of things are caused by medications. She has no allergies. So this, as far as we're concerned, is not that helpful for us. So we're going to have to get some additional tests, okay? And we're going to have to examine the patient. All right, so let's keep going. Here is the physical exam. Let's see. You guys tell me, is the blood pressure normal or abnormal? Yeah, it's normal. Good. What about her heart rate? Could say her heart rate. Yeah, it's a little tachycardic. Good. Yeah. When it's high, we say tachycardic. When it's low, bradycardic. So good. So general, the patient is in no acute distress. Yeah, it could be elevated because of pain. Absolutely. The patient has moist mucous membranes, a little bit of tachycardia, but regular rate and rhythm, no murmurs. The lungs are clear. The chest and thorax, she had a little bit of milky and white nipple discharge that was expressed. And then the abdomen is soft. And then the only thing really that we're finding here on this exam is this. Her cranial nerves 3 through 12 were intact, but cranial nerve 2 on exam showed visual field defect in the temporal fields. So basically in this image down below, it's representative of her visual fields. So on the nasal field, she could see, and then out here, she can't see. So, we might come behind her and go like this, and she can't see that. So that shows that she has a visual field defect. Now, some wise soul out there, tell me how this correlates to her car accident so far. Yeah, her blind spots are basically compounded. She can't see cars that are in her periphery, essentially. Yeah, she has tunnel vision. That's right. Yeah, good job, Matthew. Perfect. She can't see. Good job. You guys are all right. Let me clear this out and let's keep going. What tests do you guys want to order? Let's start with labs. What labs do you want to see? So CT, yeah, we'll certainly get a CT, especially because she has headaches. Anytime there's a red flag for headaches, cranial nerve disturbances, acute onset of a headache, altered mental status, loss of consciousness, anything like this is red flags, and we want to get some imaging for it. So yeah, a CMP. What else do you guys want to look at for blood tests? Get an EEG. The neurologist might be a little bit mad at you about that, but let's see the CT first for sure. Anybody else? Any labs that you want to get? CBC, yeah. All right, so somebody ordered a CMP. Let's see, who ordered this, the CMP? That was Harley. Harley ordered the CMP. So here's your CMP, Harley. The sodium is normal. Basically, everything's normal here. Potassium's normal. She has a normal glucose, normal chloride. She has a normal CO2, normal BUN, normal creatinine. So this is, grossly normal. CBC also, do neurologists not like administering EEGs. They'll want you to get a workup before. And as a, if you're going into internal medicine or any kind of field along those lines, you'll want to have a rationale behind why you're getting an EEG. So right now, basically, the reason why I said that is we don't have a good rationale for getting an EEG. And that's what you're going to learn in school, is that you have to have a reason why you're ordering this. We can't just say, headaches, let's get an EEG. If the patient had, multiple seizures, we might want to get an EEG, or if they're not waking up from sedation, maybe an EEG in that regard. But right now, we don't have enough kind of a background to get an EEG. That's all. All right, your pregnancy test is negative, so there's your guys' answer to that. CBC was pretty normal here. Here's the white blood cells. She's not anemic. Her hemoglobin's okay, and her platelets are fine. So she doesn't have thrombocytopenia or anything. The other thing is the prolactin, which could explain her nipple discharge there. We know that prolactin is a hormone that is released from the pituitary gland that primarily is for pregnant mothers of whom are breastfeeding. We know that that hormone is released in order to stimulate the breast tissue to produce milk. Okay, hope that gives a little bit of context for you about prolactin. TSH is high, so there might be something going on with the thyroid here. So Stephanie wants a CT scan. So here you go, Stephanie. What's going on here? There's an arrow for you. It's helpful. What is this? All the budding radiologists out there. Yeah, we see a mass, exactly. So the white arrow is pointing to a mass. And if we kind of remember our friend, the brainstem, that's right here. So we see part of it coming up here. We see the sella turcica here. And what CT is that the is white, and then tissue's kind of gray, and then usually if there's a bleed, that will kind of appear black. This is just part of this is an air is black too, so this is just part of the normal brain here. All right, So let's keep going here. Any other imaging that you guys want? Think more specific. So we got a CT. We got an ultrasound of the thyroid, sure. PET scan. Maybe not PET. Think a little more specific. Also imaging. Yeah, good job, Adam. Perfect. Harley, Alejandra, exactly. Good. So here's our MRI, and we have a measurement here, which tells us that there's a mass. And we know that, so here is where the sella turcica would sit, and here's the sphenoid sinus right in front. We see part of the normal brainstem here, kind of going down. That was a horrible drawing. Here's part of the cerebellum back here for your balance. And then we see this mass right here, 18.74 millimeters. So a pretty large mass there, could be causing her headaches. So what do we think this is, kind of based on the anatomy in the area? We know that based on the other scan, it's sitting right near the sella turcica. We see some abnormalities with hormonal elements. Where do we think this mass might be based on what we know so far? Any ideas? Good. Yeah, pituitary gland. Yeah, you guys are smart. I think you guys are ahead of where I would have been when I was going into medical school. You guys are very smart. Good. And what we're seeing here, could the cells from the prolactin be overgrowing? Exactly. So we're going to talk about that here in a second, Megan, because what we're going to see is that one type of cell is kind of growing and kind of outgrowing the other ones. Okay. Is it incorrect to say a tumor, or is it a mass, or is mass a very broad term? Yes, it is a tumor, and we'll talk a little bit more about it here, but you guys tell me, what are we calling this? It's on the pituitary. Do we just call it a pituitary tumor? What do we call it? Any ideas? We'll call it a pituitary adenoma, okay? So that's what this is, and what we're seeing, yeah, when in doubt, just add an oma to everything, and then it's medicine. So what we are seeing is hyperprolactinemia in the presence of a pituitary mass. So yes, we are calling it a mass. This is an adenoma, and does the name depend on which side of the pituitary? No, it doesn't. Usually it's a pituitary adenoma, regardless of what type of cell it is. And we call it a prolactinoma because we know that the lactotrophs are hyperfunctioning. So we call it a prolactinoma. Okay. So what else can we talk about here? So other causes of prolactinemia that we want to talk about is empty sella syndrome. So when we don't have a pituitary there, pharmacological causes of it. So dopamine antagonists, like a lot of antipsychotic drugs are dopamine antagonists. So you have an increase in dopamine. And what we know is, if we kind of draw out the pathway for the release of prolactin, we know that dopamine, that's DA here, is released from the hypothalamus, which causes prolactin to be inhibited from being released in the pituitary gland. Okay, and I know that you're probably going cross-eyed thinking, wait, what? So basically what's happening here is, here's the hypothalamus. Dopamine is going to be released from the brain, which tells the lactotrophs in the pituitary gland, do not release prolactin, okay? So when we inhibit dopamine, we have a negative inhibitor being taken away. So what does that result in, do you guys think? If we're inhibiting an inhibitor, You guys are probably, yeah, you get expression. Exactly. You guys remember from biology and your biochemistry, all of these things, that results in expression. So what's going to happen is you're going to get release of prolactin. So we see in dopamine antagonists, antipsychotic drugs, that can lead to prolactinemia. And the way we see it usually in men is not nipple discharge, but like decreased libido and things like that, things along those lines. And then usually in women, it's more pronounced because you see amenorrhea, so they don't have a period, they might have nipple discharge, things like that. All right, let's keep going. And then primary hypothyroidism can also cause it because TSH is an inhibitor of is a high TSH is an activator of prolactin. Okay, so they kind of work together. And there's an image that I'm going to show you at the end that will make more sense. And then the other thing is chest wall stimulation. So if you get a lot of stimulation to the nipples, you can have nipple discharge. But obviously that wasn't the case here. It's just one of those weird facts. Pregnancy obviously can cause hyperprolactinemia. Good job for all of you guys out there that was like, let's get a pregnancy test. It's so important, especially if someone doesn't have a period. The first thing you should do is get a pregnancy test. Then other things is chronic kidney disease or liver failure can also cause derangements in the prolactin level. All right. So our assessment and plan, what we want to do here, the first line treatment for this, for hyperprolactinemia for a pituitary macroadenoma, that is a prolactinoma, we want to give dopamine agonists. Why? Based on what I told you the slide before, why would we want to give an agonist? Yeah, to stop prolactin secretion. Exactly. To inhibit prolactin. Perfect. You guys are getting it. You guys are already going to be steps ahead when you get to your endocrine blocks, when you get to neurology. Good. So here is what I was just talking about. Let's talk about it again. Here's the hypothalamus, aka in your brain. And the hypothalamus is going to release dopamine, okay? Dopamine is an inhibitor of the pituitary gland, specifically the anterior pituitary, which is going to inhibit the release of prolactin, okay? So when we have increased dopamine, we have decreased prolactin, okay? When we have decreased dopamine, we have increased. So there's an inverse relationship between the two. Alternatively, for the thyroid, the hypothalamus also releases thyroid releasing hormone, TRH, which acts on the anterior pituitary to release TSH. Does this make sense to us now? So we have a high TRH, we have acting on the anterior pituitary, which causes TSH, which causes increased prolactin, okay? And then there's other hormones that can affect the prolactin level as well. We can, in renal failure, we get decreased elimination of prolactin, so it can build up. And then also estrogen causes increased prolactin, and then prolactin inhibits the release of FSH and LH, which obviously affect the menstrual cycle. So I hope this makes a little more sense to you now. When we have increased prolactin here, what we're seeing is prolactin is going to go inhibit gonadotropin releasing hormone, GnRH, which is going to affect the hormones that affect the menstrual cycle. Okay, so I hope this is all kind of coming together now. It is very complicated. This is a little bit of endocrinology, a little bit of neurology as well. But here's what we're talking about here. What we're talking about is a prolactinoma. So we're going to give dopamine agonists. And the thing about medicine is if you understand the why behind it, the treatments you'll figure out, okay? If we know that dopamine inhibits prolactin, let's give a dopamine agonist, okay? You might want to think that surgery is first line, but it's not actually. We give these dopamine agonists like bromocriptine and cabergoline. All right. And what this is going to do is lower the prolactin level and decrease the tumor size. And then, you know, there are other kinds of pituitary hormones or pituitary adenomas rather. We know that if there's one releasing adreno or ACTH, adrenocorticotropic hormone, that's ACTH. This causes essentially Cushing's disease. So you get the round belly, the buffalo hump, the stretch marks, things like that. Then there's one for growth hormone. What this causes is acromegaly in adults and gigantism in children. So we give somatostatin analogs, which basically block those hormones. So octreotide, the otides. And then there are some that are non-functioning, and that's how we delineate these tumors, whether they're functioning or non-functioning. The majority of these tumors are functioning. Some are non-functioning, but these are the most common ones, the most common being a prolactinoma. And then we have other ones that are ACTH and growth hormone. And based on the patient's symptoms, we can kind of discern which one it is, as we kind of talked about. All right, so let's keep going here. We'll talk a little bit about the pathology. There's our dopamine agonist there. And then we'll want the patient to follow with neurology, because what we'll want to do is get an MRI of the brain to monitor the size over time, make sure that it's shrinking and not necessarily growing, and that we don't want to intervene. All right, so here's a little bit more about the pituitary. Here specifically, we'll remember that here's our pituitary gland. We have the anterior lobe and the posterior lobe. The one that we're focused on mostly is the anterior lobe. All but two hormones come from the anterior portion of the pituitary. We know that ADH comes from over here, and oxytocin, I believe. And then, you know, we have up here, if you remember, here's the hypothalamus. This is our friend, the hypothalamus that we've been talking about. And here's the optic tract. We have we know that the optic nerve comes in, and then it comes into the optic chiasm. So meaning chiasm, meaning cross. Okay. So when we look here, this is what we're seeing in a different field. So here's cranial nerve 2, and it comes, you know, from the periphery, comes here and then crosses. So chiasm meaning cross. And we're going to talk about this, how this actually relates to the vision and the visual defects that we're seeing in the patient. And then here's our sella turcica. It's a bone that the pituitary gland sits in. Sella turcica literally means Turkish saddle. So if you think about it, it's like a cute little saddle for the pituitary gland to sit in, and that's what it is. It protects the pituitary gland in a little bony encasement. Here's the sphenoid sinus that we talked about here, and you know, up here we have, you know, blood supply here. It's part of the carotid, but we're not really going to get into that just now. All right, let's keep going. So the way that we delineate these is based on size, microadenoma, macroadenoma, and I believe 6 millimeters is the distinction between the two. And then we also kind of classify them based on their cell type, as we kind of talked about. If it's based on prolactin, so from the cells of lactotrophs, this is a prolactinoma. If it's from growth hormone, this causes acromegaly in adults, and this is from the somatotrophs. Somato meaning body, growth hormone acts on the body, okay? Cortisol, this causes Cushing's disease. This is from ACTH. We just talked about that. ACT, it's a lot harder than it looks to write this. I should be better at this by now. Thyroid hormone, obviously this can cause problems with the thyroid. And then FSH and LH, this is from the gonadotropes. And what we see here, here's a little bit of a lesson on, endocrine here. So the hypothalamus is going to release all the releasing hormones, okay? So we have thyrotropin releasing hormone, TRH, growth hormone releasing hormone, corticotropin releasing hormone, gonadotropin releasing hormone. All those RHs come from the hypothalamus, which is released through the infundibulum to the pituitary gland, which acts on the pituitary gland to release the stimulating hormones, which makes sense. And these kind of hormones act through the blood on the target organs. For instance, the thyroid stimulating hormone acts on the thyroid. Okay, great. It acts on the thyroid to release thyroxine and T3 and T4 hormones. Then growth hormone releasing hormone acts on the pituitary gland to release growth hormone. And this acts on the liver to release insulin-like growth factor 1, which is actually the thing that we measure in acromegaly, because growth hormone has a very short half-life. And then, as you can see, ACTH goes and acts on the adrenals to make cortisol. And then the posterior pituitary, here's our, they don't actually show it in here, but ADH is over here as well in oxytocin. What causes the outgrowth of the cells that form the tumor? So I think what you're asking is, what causes the overgrowth? So it's just the stimulation, basically. What's happening is you're getting an increased stimulation of the prolactin cells. So because you're getting decreased dopamine, you're getting overgrowth of those cells. So you're getting an increased stimulus, which is causing the growth of those cells. There's a lot of kind of studies that are looking into, why do people get pituitary adenomas and, all of that. So some of that is unknown, but there is an increased stimulus. That is what we do know. Okay. All right. So when we talk about the clinical presentation of this, we know that the 1 in 6 people actually have pituitary adenomas. So somebody in this room might have a pituitary adenoma, or maybe not. 1 in 6 is not that super common that somebody in the room may. But what we look for in the clinical presentation is hormonal. So our patient had that nipple discharge, amenorrhea, lack of a period, or neurologic. So we know that there can be neurologic causes, headaches, cranial nerve disturbances, things like that, loss of vision, we had that. And then most of them truly are going to be incidental. So somebody's gonna come in for something completely unrelated and get a head CT, and then you're gonna find it and then be questioning whether you need to do something with it or not. All right, and the thing about it is most people that do have pituitary adenomas are asymptomatic. But what we see, I was wrong. I said 6 centimeters, but it's 10, or I'm sorry, 6 millimeters, but it's 10 millimeters is the delineation between the two. And if it's greater than 40, we call that a giant adenoma, not that common. But a microadenoma is less than 10 millimeters. A macro is greater than 10 millimeters. If you remember, our patient's was 18, so it's definitely a macroadenoma. And then we can see things like headaches, which our patient had, nausea and vomiting because of increased intracranial pressure, hypothalamic dysfunction, so problems with the hypothalamus releasing hormones. We can see bitemporal hemianopsia, which is what we saw. So that's the cute way of saying loss of peripheral vision. So remember, our patient had kind of, it looked like this, where she couldn't see. And I have a slide next that's going to talk about this. And I think I might actually end on time, which is probably a huge shock to you all. But the lateral temporal, meaning closer to the temporal bone, we delineate it by nasal and temporal, or medial and lateral. This is called bitemporal, meaning two temporal, hemianopsia. So that's what that's called. And we're going to talk about that in a second. We can see hydrocephalus from increased intracranial pressure. We can see diplopia, which is double vision. We can see postnasal drip. So if there's like a problem with the CSF, less common. And we can see maybe meningitis, that's less common too. Do all pituitary adenomas have a hereditary component? No, they don't. Not all will or can. Some are just random. When we talk about it, you know, is it environmental? Did something set it off, or was there an exposure? You know, there's not always a hereditary component to it. It's a great question. So as we kind of talked about, we delineate it by, you know, secreting versus non-secreting. We know that secreting is more common, and prolactin is the most common. So when in doubt, call it a pituitary, or a pituitary adenoma, of which is a prolactinoma, because that's most common. Okay, so let's talk about the visual fields real quick. And this is my last slide, I believe. Or I think I might have one more. I might have just lied to you. So here is our bitemporal hemianopsia. Okay, so we remember that our patient's visual field, we lost basically the temporal fields here. Okay, so we're going to walk through this and figure out why this was the case, because if you know why, you can figure out a lot of things in medicine. And I encourage you, whenever you're in medical school, don't just memorize things, understand why, and you'll be able to figure out so much more, and you'll be able to remember it more. Okay, so let's start up at the top. So we see that we have, let me get a better color so you can see it. We have the left visual field and we have the right visual field, okay? We know that things that come from the temporal visual fields, meaning the lateral visual fields, okay? So we can delineate this by medial. So we have two medial fields, and we have two lateral visual fields. Let me put this in a different color so you can see it. And here's the lateral visual fields. We know that the lateral visual fields specifically go to the medial part of the eye. Okay, and I know that that's like, oh my gosh, it's like you're probably cross-eyed again thinking about this. So what we see is the lateral visual fields go to the medial aspect of the eye to get processed. Okay. All right, is everybody good so far? It's gonna get a little bit complicated. All right, so then you know, just for completeness sake, we know that the medial part of the visual fields go to the lateral aspect of the eye. Okay, so they kind of cross like this. All right, so now the temporal lateral aspects of the visual fields go to the medial aspect of the eye. Now, the medial aspects that come in here and they cross, okay? So they come in here and they cross, all right? And we know, and let me get rid of that so you guys can see those colors crossing, okay? So remember, here's our lateral come in here, and our lateral comes in here, all right? And then here's the optic chiasm, meaning the cross. We know that it crosses here. And our huge tumor was where? Based on our bitemporal hemianopsia, where was our tumor impinging to cause that visual field defect? Draw it in for me if you guys are capable with the annotate tool. Draw it in for me where you think it might be, or stamp it. Yeah, good job. You guys are spot on. Perfect. And it shows me you guys are learning stuff. This is hard stuff for people to follow. People have to sit with their notes and think about this, okay? So good job. And that's exactly where I would place the tumor. You know, and it's right here. It's impinging on the optic chiasm, because what we're seeing is we're losing this part of the visual field and we're losing this part of the visual field. Okay, so she's getting into a lot of car accidents. Her husband's like, look, I'm tired of this. Our insurance plan has gone up too much and she can't even drive anymore. It's been a nightmare. And she's lost her visual field. So you can't see cars that are coming, you know, in her periphery, because we know that the lateral aspect goes to the medial on both sides, comes and crosses at the optic chiasm. Okay, I hope that makes more sense to you now. I want you to understand why, and not just remember, you know, bitemporal hemianopsia, pituitary adenoma. If you know why, you know so much more. All right, so let's keep going here. And finally, here is the workup. I'm not going to show you the video. You have access to the slides, so you can go watch the video. It's pretty cool. When we talk about surgery, it's a transsphenoidal procedure. So they go in through the sphenoid sinus, through that bone there. They get access to the sella, break the sella, and then kind of go through and take some of the take the tumor away, essentially. But in our case, they don't need to do that. All right, so here's our kind of breakdown for our treatment. And this talks about incidental ones. So basically how we delineate is functioning versus non-functioning. We kind of talked about that. And then macroadenoma versus microadenoma. And we remember the 10 millimeters is kind of our cutoff there. In other words, greater than 1 centimeter is a macroadenoma, whereas less than a centimeter is a microadenoma. And if it's a macro, we want to do visual fields testing. So test those visual fields to see if it's impinging on the vision. And then if there's a visual field defect or neurologic symptoms, we want to send to our friendly neighborhood neurosurgeon. And this is kind of the procedure that they might consider doing, is that transsphenoidal resection of that tumor. It's a you know, it can be, it's rather invasive in that it kind of goes through the sphenoid. So this is not something we want to really jump to right away, but we're not going through like the cranium or anything. So it could be argued that it's not that invasive. And then if there's not any visual field defect, then we want to repeat that MRI like we talked about, and then monitor for increases in size. And then if it's functioning, like we talked about, this was the kind of side that we were on. It was a functioning prolactinoma. We treated with dopamine agonists, because we remember dopamine decreases the production of prolactin. And then if it's growth hormone or ACTH, so if it's acromegaly or Cushing's disease, we will refer to neurosurgery and endocrinology for hormonal inhibitors, basically. All right. This should be my last slide if I'm not mistaken. Let me see. Hopefully I didn't lie to you guys again. Yeah, it is. So before you all go, and I finish almost on the dot, let me launch the poll again for you. Let's see where you guys are at. So please fill out that poll for me. Let me know where you guys are at. And then after you guys answer this, you're certainly free to go. You're free to stick around for a little while. I'm going to be staying around for a few minutes to answer any questions you guys have about the cranial nerves, about pituitary adenomas, about medical school, about anything you guys want to ask. I'll stick around. But let me share these results with you guys here. It looks like nobody says they know nothing, which I'm humbled by. And you guys kind of talked or kind of all bumped up, it looks like. Most of you guys say that you know some. I'm very humbled by that. And it's been an honor to kind of teach you guys this week. I always love doing this. You guys are very, very smart and a good audience. So thank you all for coming. Hopefully we see you guys next week. If you guys are trying to escape your family before Thanksgiving, we'll be here. We'll be talking about joint pain. So there's lots to talk about with joint pain. I'm going to give you guys a few cases to kind of run through. So if you guys have no other questions, you can certainly sign out. Be sure to do the quiz and the SOAP note. Otherwise, I'll stick around, and you're free to stick around and ask questions if you'd like. We have one question. How would a microadenoma be discovered if it's not causing any visual defects? Exactly, that's a great question. And the thing about it is microadenomas are often discovered incidentally. So we call those incidentallomas. They're kind of discovered because of something else. You know, say the patient has, you know, chronic migraines, and they get a CT scan and it shows a microadenoma. The pituitary adenoma is so small, it's likely not causing the headaches. They just have headaches, or they, you know, they have chronic migraines, and the pituitary adenoma just happens to be there. So we call that an incidentaloma, basically. I hope that answers your question. All right, let's see what else we got here. I was a little bit confused on the second to last slide on the visual fields. If the lateral fields are what the patient can't see, would it be inverted and actually be the medial part of the eyes that are blacked out? So let me show you that again, Sammy, so you can see it. And it's difficult. So let's walk through it again so that you can understand a little bit here. And for anybody else that's still around that is also confused, we'll kind of run through it again. So let's start here. Here's the lateral fields, okay? Here's the medial fields. We know that the lateral fields go to the medial aspect of the eyes, okay? I think you guys have that, all right? And then I'll show you why, not why it's the temporal fields, but why it's not the medial fields, okay? And that's because the medial fields go to the lateral aspect of the eye, okay? And then what they do is they go out here. They don't even cross. So they kind of avoid all the action. Whereas the lateral fields that see laterally come to the medial aspect and then they cross. Does that make sense? So if we have a big tumor sitting right here, it's going to impinge on that. Whereas the ones that are lateral, that are from the medial fields, they don't actually cross at all. So they won't be affected by that pituitary adenoma that's sitting right on the optic chiasm as it crosses. Okay, does that make a little more sense, Sammy? So yes, so in the diagram, it would be the right part of the left circle. Yes, basically. So the right part of the left circle. Yes, yeah, exactly, yeah. So basically it would look like this, that we can't see. So temporal meaning the outer sides, like this. So if we look at this, this is how it looks. Both of the outer sides are kind of blacked out, if you will. You can't see there because the lateral fields are these. So basically, oh, I just did that wrong. That's not right. Ignore me. It's this. Let me give you an actual. I'm still on the eraser, sorry. Okay, here it is. So it's going to be this that you can't see. So you kind of have to think of it separate from that actual image. So what you're going to see is this. Oh my God, this is horrible. Like that, because this kind of crosses like this. So the temporal fields go medially, they cross, and because of that, you're not going to see on the outer sides. Okay, does that make a little more sense, Sammy? Hopefully. Yes, okay, good. I'm glad you asked. It's a hard thing to kind of understand. Is there any impact on SCN function looking at the nerves that branch out then? Any problems with circadian rhythm? There could, maybe be problems with circadian rhythm. It is not, when we talk about circadian rhythm, there is parts of that are hormonally regulated. So, you can't say no, but like you're probably referring to the suprachiasmatic nucleus, maybe it could, that might be a good question, honestly, for like a neurosurgeon or a neurologist. But I'm sure there could be, but I don't know necessarily for sure. That's a great question, Hannah. I would assume that if there is problems with the circadian rhythm, it might be because of like hormonal imbalances as opposed to it affecting the suprachiasmatic nucleus. That's my guess, though. That's a great question. I assume that you're like a neuroscience major or something, aren't you? Oh, based on the diagram. Okay, I thought you might be that's a good question. It is kind of in the hypothalamus, and it's kind of shown out of plane. So if you have a problem with the hypothalamus, then maybe yes, but not probably because of the pituitary adenoma. I assume it's probably because of the hormonal imbalance. Okay. Any other questions out there for those of you that have stuck around, or if you have questions about medical school, let me know. Rachel has a question about med school. Go ahead. Absolutely. See you guys next week for those of you that are signing out. A bioengineer. Okay. Okay. All the suspense is building while we wait for Rachel to type. What would be your suggestions for someone who's trying to play catch up? Okay, that's a really good question. So I would say that it depends on your schedule, Rachel. And that I know that that's not a great answer. And we could always, sit down and plan a mentor session as well. But what I say is it depends on your schedule, because if, you have to take, biology and chemistry and biochemistry and physics and all these things that can be tough when they're taken all together, and you're working full time, then maybe you want to decrease your load. It just depends on what you're doing. If you're going to school full time, some of that might be manageable, because the last thing you want to do is like inundate yourself with work and then not getting to buff your resume towards, okay, you're good with classwork. Okay. Yeah. So I recommend, getting involved, you're off to a good start, getting involved with like virtual rounds and stuff. It gives you stuff to talk about. You might do shadowing. They always look for shadowing and kind of things that demonstrate your involvement in medicine and dedication to medicine. So, any jobs that are going to put you kind of in the face of medicine, whether it's MA, EMS, scribing, if you're a nurse, anything like that, that's going to put you there. Lots of shadowing hours is always good, and building relationships with physicians and everybody. Yeah, good. You're a medical scribe. Great. So getting, hours doing that is going to get you lots of and then getting hands-on experience is also valued often too. I was a medical scribe 1,000 years ago as well, and it teaches you a lot. So be sure to ask questions and learn, and always. I always give the recommendation for pre-med students. Have a notebook when you go and shadow and when you go and scribe, and write down things that were, impactful to you, or left an impression on you, or resonated with you. So when you get to your medical school application, you have things to write about. Yeah, and getting hands-on experience and shadowing is very hard during COVID. Hence this is one of the reasons why, we created virtual rounds is for you guys, because, while some people are able to still be in the hospital, it's hard to for just shadowing and stuff. Yeah, don't want people in the hospital. Yeah, they just want to minimize your exposure, basically. So I would say, getting as much exposure as you can to medicine, whether volunteering, things like that. And if you haven't gotten experience in the hospital, reach out to private practice clinics and people of whom are, on their own. The worst thing people can tell you is no. So you're never going to know unless you ask. Don't wait for the opportunity to just fall in your lap. Sometimes you have to go out and chase those things, and doing, internships and shadowing experiences and different things in medicine is definitely going to show your dedication. So I would say, having a good quantity of shadowing hours and experience in medicine is great. And then, having experiences that demonstrate your interest. I hope that answers your question, Rachel. What year in medical school would you consider the most educational? I would say it depends on how you kind of look at educational. I would say actually in studying in the books and doing lots of academic coursework, I would say second year. Based on your school. My first year of medical school was my first year was all kind of basic sciences and foundational, and then the second year was all pathology. And then after your second year, you take your first step of boards, and while you're learning all the pathology, you're preparing for your boards. And then your third year and fourth year are usually your clerkships, so your rotations. So I would say that second year is probably the most educational in that regard. But then when you get out to third and fourth year, you kind of see all those things come together and are representative in patients' pathology. So I would say probably second year, but then third and fourth year, you see it in real life and you get to kind of work on that knowledge. I heard a lot of people being EMT or a CMA during their undergrad to gain clinical experience, but training takes so long. Do you know how people are able to do that if they're in accelerated programs? Yeah, so sometimes so there are programs that I know are offered through community college or through different four-year institutions. That is to be an EMT basic, that is one semester, a semester-long course. So it does take one semester, and sometimes community colleges or different four-year institutions offer them at night. So you might be able to get into courses like that to be an MA or an EMT in order to get additional experience. But you have to kind of look and see when those courses are offered. I know there are accelerated programs. Sometimes they offer those courses in between semesters, like the mini mesters or whatever they call them, where you're able to do it you're there all day for 2 weeks or something. But you just have to see what's offered. It depends on the institution. But don't kind of overdo yourself if it doesn't fit in with your schedule. I would rather you have good grades and stuff than kind of exert yourself and try to do EMT just because everybody's doing it. Find the experience that you're most interested in and kind of indulge in that. What are your suggestions for a letter of recommendation? So my biggest suggestion for letters of recommendation is, obviously have one from a doctor. And if you plan to apply to DO schools, also plan to shadow some DO physicians, because a lot of DO schools, osteopathic schools, will want a DO physician to apply or to write a letter of recommendation on your behalf. But my biggest suggestion for letters of recommendation now and for the rest of your life is make sure you're asking people of whom know that you have a good relationship with and you've built rapport with, and can write a good letter of recommendation on your behalf. If they are, reputable and you don't know them that well, sometimes those letters can be okay, but often the best letters are going to be the people that can vouch on your behalf. So sometimes that's relationships with professors that you've built over time. When I applied to medical school, one of my letters of recommendation was from an English teacher in the honors college that I was in, because it was someone that could attest to my character as a student. Then I had one from my pre-professional program and one from a physician. So I recommend, one, getting them from people of whom know you well, and two, getting it from kind of multiple different perspectives that show your candidacy as a student and as a person. Does that kind of help? Would you recommend getting different certificates as an MA or EMT during undergrad? I feel like it might be a distraction. I don't necessarily recommend it one way or another. If you get it, great. And if that's something that you're interested in is being an EMT or an MA and you want to work, sure, do it. But if you think it's going to take away from school, then that's okay too. Or if you have time to do it, sure, you certainly can. I don't think it's not a prerequisite for medical school. I wasn't an MA or an EMT. I got my degree in medical laboratory sciences and worked at Johns Hopkins, a lab scientist for 2 years, and that was kind of my exposure to medicine. I worked as a scribe before I did that. And had shadowing hours and stuff like that. So if you can find those experiences that you want to do, great. There's lots of different experiences in the hospital that you can do, like EKG techs and things like that, where you get kind of hands-on professional training. So, look for those experiences that fit your personality. Don't do something just because you think, you need to do it to get into medical school. You're very welcome. Anybody else have questions? You're very welcome. If you guys have any other questions, you can always contact the email at MotivateMD. They can certainly forward them to me. And remember, whenever you get to your applications and stuff, we're certainly here to help, whether it's for essay editing or mentoring or anything. You could always find us and edit your essays. That's where I got my start with MotivateMD. So if you guys need any help with anything, or save your questions and ask them next week during virtual rounds if you have any.